Hello, and we welcome you to the Thoracic Surgery Clinics podcast. Published for over 30 years, Thoracic Surgery Clinics is a quarterly publication consisting of review articles devoted to a central topic important to general thoracic surgeons. The series and the podcast can be found at www.thoracic.theclinics.com. I'm John Vassallo, the managing editor for the series here at Elsevier, and for our seventh podcast, we will be discussing selected articles from the November 2023 issue on lung cancer screening. While the criteria for the National Lung Screening Trial were recently expanded in 2021, lung cancer screening rates remain much lower compared with other well-established cancer screening rates and remain at a low 5.8% of the eligible population. Here to discuss why that is and how to improve it are the guest editors, Dr. Mimi Seppa, Associate Professor of Surgery at Indiana University School of Medicine and Deputy Chief of Surgery at Rotherbush VA Medical Center in Indianapolis, Indiana, and Dr. Kei Suzuki, Director of Thoracic Surgery Research at the Schar Cancer Institute and Assistant Professor at the University of Virginia School of Medicine in Fairfax, Virginia. Leading the discussion will be our consulting editor of Thoracic Surgery Clinics, Dr. Virginia Lytle, Chief of Thoracic Surgery at St. Elizabeth's Medical Center in Brighton, Massachusetts. Welcome to all three of you, and over to you, Dr. Lytle.
Thank you, John, and welcome, Dr. Suzuki and Dr. Seppa. So as we know, this thoracic surgery issue addresses not only one of many of the challenges in optimizing lung cancer screening rates, but also what other advances are being made to complement the low-dose CAT scans and facilitate our efforts to combat the number one cancer killer. There are over 350 deaths a day attributed to lung cancer in the United States. Although we have made progress in a 5-year survival rate to about 26% from about 20% several years ago, we still have a long way to go compared to many other solid malignancies. So I'd like to thank both of you for co-guest editing this recent issue. We could have discussed many wonderful contributions from our invited authors whom you selected and invited, but I have some questions for you about several selected topics from the issue. Before we get started, however, I'd like to ask each of you how you got interested in your professional focus on lung cancer screening and lung cancer. Let's start with you, Dr. Mimi Seppa.
Sure. Thank you. In brief, I'd say I got into the domain of lung cancer screening really via serendipity. Timing is everything is what they say, right? And so I would say I graduated from training in 2011, which is right when the NLST results were published. And so at the time, since I was the junior partner who had the quote unquote most amount of time, spare time, it fell in my lap to sort of develop and build the lung screening program at IU. And so, with that being said, it was such a new field. There was so much potential. There was so much to be done, everything from patient and provider education to programmatic development, and improving access to screening. And then, of course, there's, the whole concept of all the future adjunct modalities and research in that area to try to improve our screening rates. And so, what I ended up finding out, and I think a lot of people who were in a similar scenario, is that once you get started, it's so easy to get engulfed in lung screening because there's so much potential.
Great. Thank you. Yeah, I agree. We still have a long way to go, but we have made amazing progress with folks like you who are so passionate about this issue. So, Dr. Kei Suzuki, why don't you tell us how you got interested in investigating lung cancer and then optimizing screening rates at your institution?
Yeah, thanks for having us. I think as a thoracic surgeon, one of the most rewarding aspects of our job is to be able to tell a patient that their cancer is cured after surgery, which we have a good shot of in doing with stage 1 patients, right? So, and screening is probably the best way to capture these patients at stage 1. So when we know that there are so much room for improvement in this area, that whether that's improving the screening uptake or developing screening adjuncts, that naturally became, one of my clinical and research focus. So that I would say that's how I got into this topic.
All right. Well, let's start off with some of our selected topics. For starters, we'll talk about barriers to lung cancer screening. So you invited Catherine Leopold and Dr. Carter Bawa to write about barriers to lung cancer screening access from the perspectives of the patient. Kay, why don't you start us off? What are some of the major patient-specific barriers to screening that the authors summarized?
Yeah, so I think in general, it's important for us to understand that barriers to screening is multifactorial. So there are patient level, provider level, system level barriers. And I think we as clinicians have to understand the specific barriers so that we can formulate sort of barrier specific plans. This chapter looks at the patient barriers, within which there are different factors to consider, right? So they mentioned the cognitive factors. So that usually is lack of awareness on the patient side, sort of the low perceived risk of lung cancer. Those are the cognitive factors. And then there are the access factors, which can be both patients, I guess you can consider that patient or system level barriers. And then psychological factors, that's usually sort of the fear, the mistrust. And I think, it's important to understand what the barrier is at each institution for each patient so we can plan accordingly, right? So I think the chapter talks about, for example, for cognitive factors, right? Lack of awareness, people have tried educational materials such as, videos and pamphlets. And I think in general, they conclude that they improve patient knowledge, but not necessarily the screening uptake. And then they talk about things such as decision aids, which are usually done through face-to-face or video formats, which have been shown to be successful in improving uptake. Phone calls, I think that's been shown to be effective, especially in older, lower income and the current smokers. And then sort of the community-based education. And this is where I say it's important to understand the local factors, because you have to understand who is not being screened and then understand each community to kind of say, what is the best venue to do these community-based education? Because that may be at a church, it may be at a recreation center, right? So I think it's important to understand your patients and the local factors. I think as far as access goes, I think we know, and a lot of hospitals have navigators, which are known to increase uptake. So that's something that I think everyone should have for lung cancer screening. And I think those are the main things that the chapter touches on, which are all important and relevant issues.
Thanks. Actually, I just want to ask you, Kay, because I know when you and I worked together in Boston, some of the things you were doing specifically to reach out to patients directly was basically in the radiology waiting room and approaching patients there. Can you elaborate on that?
Yeah, I mean, that was just a sort of how do we get to these patients? And I thought if they are, that was more for the research that we were doing. I thought we needed to capture the patients physically, so we were trying to approach them in the radiology waiting room because they're already in the hospital. I will say something I learned from my Boston Medical Center experience, which is a safety net hospital, and again, I emphasize and understanding your local patients, and where I reach the challenge is how do I get to these people and identify the stakeholders in each community. It's not necessarily the local primary care physicians. That's not necessarily who the patients go to, right? So that's kind of where I left the hospital. So I didn't really explore that further. But I was being told sometimes it's a church, sometimes it's a recreation center, and each community is different. And hospitals have these community outreach type of programs, and that's where you sort of need to engage them because they understand the community better than the physicians do, I think. So that's one thing I learned from that experience at Boston Medical.
Yeah, I think that's an excellent point. And that addresses the whole concept of, well, one, to reduce the disparities in healthcare, connecting with community leaders so they can help address some of the mistrust that potential screened patients have in our system.
Yeah, so I actually just wanted to add, with regards to access to care, it's interesting that you're bringing up the safety net hospitals and how patients don't necessarily have access to, or they don't have regular primary care, and therefore the whole concept of screening patients or educating them through primary care might not be available. One of my collaborators is actually an ED physician. His name is Dr. Nicholas Pettit, but he was exploring this, and we've looked into I guess, providing the educational piece in the ED, because patients were coming to the ED. And what he had identified was a lot of patients were getting diagnosed with cancer, whether it was colon cancer or lung cancer, or incidentally by showing up in the ED for something else, right? And using that as a teaching moment for education about lung screening and facilitating and kind of connecting them with the lung screening program. And this is fairly early on in the early stages of all of this, but we've looked into this and have captured a good amount of patients through that. And then, of course, the other, with regards to patient barriers, that I'd have to say the one thing that intrigues me the most with regards to this in this chapter was the whole concept of patient mistrust, right? So patients, when healthcare systems or institutions are advertising, oh, go get a $49 lung scan, right? A lot of patients in the focus study groups literally, voiced a concern that this was meant to be a bait and switch. Like, they're gonna give me a cheap scan, but they're going to find a whole bunch of other things and then make me get these extra tests, truly believing that it was a marketing thing for the healthcare system, as opposed to an actual national guideline that this has been proven to save lives, et cetera. And so, and I think laced with that is a little bit of the stigma, right? We can't emphasize enough how patients who smoke, so, we're scanning a high-risk patients, and high-risk, a big component of the definition is smoking history, right? Is the stigma of smoking and how patients feel guilted as though they kind of did this to themselves. And so they themselves are not seeking lung screening because of that stigma. And, I've heard this before. I'm sure you have too. I'm sure you'll hear it again. But, when a patient comes in with colon cancer, we don't shame them and say, how much fiber did you eat? Or did you have enough vegetables? Or, how many sexual partners do you have? Or, were you on OCPs, with regards to risk factors for other cancers, right? And so the emphasis on smoking, while important, needs to also be kind of taken away so that that patient doesn't feel that stigma associated with potential of being diagnosed with lung cancer.
I think people have tried those ED interventions that's worked. And again, it comes back to understanding your local hospital, where are the best places to capture these patients. So ED, I think, is an obvious one. But we looked in our hospital where these lung cancer screen eligible patients are being seen most commonly. So yes, ED is number one. And then number 2 and 3 were cardiology and pre-op clinic, which makes sense because they're probably like smokers and whatnot. But, it helps us. Now we're trying to reach out to like the preoperative clinic to raise awareness. But, I think it comes back to this understanding your local issues and figuring out how to best attack and how do we best raise awareness within your own hospital, right? So I just wanted to add that to your whole ED intervention topic.
Great. Those are all excellent suggestions and fodder for thought for our audience. All right. Next area that Drs. Hassan, Aranwensi, and colleagues from Dartmouth and City of Hope wrote about access to lung cancer screening. They wrote it. They addressed it on as a multi-level challenge, and that includes patient issues and challenges, which you guys just referred to. But there's also the provider and the system challenges. So we heard from the previous authors about the patient barriers, which you guys summarized very well, including lack of awareness, psychological challenges, and then also the stigma, et cetera. So Dr. Seppa, I know you have led the screening effort in Indianapolis area, or at least have experience in increasing awareness. What are some of your tricks of the trade?
Well, I think there were so many different levels in which we had to do this, right? So, first and foremost, is about relationship building, right? So relationship building with the pulmonologist, with the primary care folks, and then access to patient care and educating them to raise awareness, right? So, we did a lot of talks. So everything from lunch and learns, going to departmental meetings and talking to the family practice group, talking to pulmonary, as much as we could. Whenever we had the opportunity, we gave presentations at cancer center meetings. Another platform which we used and the American Cancer Society uses, and our cancer center also uses, is ECHO, which is it stands for an extension for community healthcare outcomes, and essentially it's a platform whereupon we use Zoom, right, to reach out to multiple institutions within the area. And honestly, some of our ECHO series had audiences from across the country, right? And using this as a platform to promote and increase awareness and discuss all the issues with lung screening. And when I say issues, not so much the awareness and lack of awareness, but then all the hurdles to lung screening, right? All the systems hurdles, all the things that come up when you try to start a lung screening program. And so we did all of those things. We also advertised, right? So when the lung screening program started, we did everything from newspaper ads to wall clinics and clinics. We had a radio ad at one point, and then reaching out to local news stations, right? And, increasing awareness that way by either talking about lung screening and lung cancer, especially during Lung Cancer Awareness Month, for instance, right? But then also sharing success stories. So we did a lot of that too.
And what have you done in your EMR to make sure that the primary care doctors have it sort of on their checklist, or just in their medical record documentation? They have to check off all the screening criteria, not criteria, but confirm that their patients are eligible for or are up to date on their colonoscopies, their mammograms, and all that sort of stuff. Have you done anything in your EMR with regards to lung cancer screening? Because that is not part of my system for sure.
Yeah. We have not yet, and boy, would I love to, right? So that is something that's slightly easier to do, and I work in the VA system as well as in the private sector, right? So in the VA system, there's a universal system, we call it CPRS, and those check boxes is flu vaccine, colonoscopy are there for primary care. Lung screening is not yet. And that's challenging. And we are trying to work on that. Similarly, we are trying to work on that on the at the IU side, IU Health side, right? The hardest part about being able to incorporate this on a checklist or in the EMR is the collection of tobacco use data, right? So having reliable information, and it's not always that easy, right? It's because some patients smoke 2 packs per day for 3 years, but then they quit, and then so it's not something that can be readily computed. But and then of course then there's the collection aspect of it, having reliable collection of the data, and so I think that's probably the biggest hurdle to getting this built into an EMR system. It is possible. I do know it exists. I believe they have that at Duke University through the EPIC system, but we have not been able to successfully build it yet in Cerner or CPRS.
Okay, great. And another big challenge also with the screening, and I'm just going to address this now and start with you, Dr. Suzuki, adherence rates, because that's another big challenge that I'm encountering. And a lot of it is educating the PCPs, because they're sometimes responsible for ordering the subsequent, the 12-month or the 6-month scans. We have data in the literature to support centralized screening programs, but that's not always the case in most of the parts, in a lot of parts of the country. So what do you guys do, Kay, at your hospital optimize adherence rates with follow-up imaging?
Yeah. So, this somewhat ties back into the whole EMR issue. So we actually, I think one simple thing, I guess before even adherence, going back to your whole PACure documentation, I think that's that's a general problem. And I think the published rate of undocumented PACure, if you were to review any charts, in the order of 30%. And we show that in Boston. We show that we are showing the same thing at my current job. So I think that's a simple fix. So every time we go and give a talk to like the PCPs and whoever, we emphasize that because if we're not documenting that, we're obviously not screening them because that's one of the criteria. So I think that's one. We actually have in our hospital built into Epic an Epic alert. It's called a care gap, which prompts the PCPs of the things like Dr. Seppa mentioned, like vaccinations and whatnot. That was already in place when I came 2 years ago. And then we built into it a lung cancer screening alert. So as long as someone documents a PAC here, the age is going to be there. So then the PCP will get a prompt. So it's up to the PCP to then, there's still other barriers from there, like finding a time to have a shared decision making and whatnot. But we show that pre and post installment of that alert, the uptake went up significantly, went from 2% to 20%. So it works. It's still 20%, so there's still more room for improvement, but that helps a lot in sort of overcoming the physician provider barrier, I guess. And I think they will then get alerts every time they're up for the next one. So I think the EMR alert is a good way to overcome these barriers. I think having a screening center where it's sort of a centralized care also would help. So our hospital does have actually an all-encompassing screening center. We have a screening cancer prevention center where we can take on all cancer screening patients. They get evaluated for every cancer screening eligibility. So, as long as they come here, like we wouldn't miss those because that's all we do in that center, right? So I think you can attack it from different angles. I think EMR alerts helps a lot. PACU documentation is a huge area of improvement that every one of us needs to kind of work on. But I think those are from an IT perspective, from a system perspective, those are the different ways I think to increase both uptake and adherence.
Great, thanks. And with regards to your screening center, is that where all the tracking is done? Is the screening center responsible for tracking adherence rates and follow up and sending out letters to folks to let them know they have to come in and get another scan, at a certain interval?
If they get referred here, yes, but not everyone gets referred to the screening center. But the PCPs will get the alert for the next CT. So as long as the PCPs are seeing it and closing that care gap loop, so to speak, then we haven't looked at our adherence rate. I guess that's one thing we should look at, but I'm sure the alert helps in that regard too.
Yeah, adherence rates are a real challenge when you have it in the PCP's hands. I mean, not to knock PCPs because obviously they send us patients for one, but also we all want to work together to optimize the outcomes for our patients. Mimi, maybe you can address you're part of the VA system, but you also have more private practice. So how do you balance, or can you just comment on what the VA system does to optimize adherence? I would think that it would be very systematic, but it is a government-run hospital, so I don't know. And your other practice, is it more challenging? Maybe you could address that or talk about that.
Yeah, absolutely. So I do have the benefit of having seen lung screening actually in 3 different systems. So one is a private system, the other one is a county hospital, and then the VA system is the other one. So I'd say the VA system is all centralized, right? It's a fully centralized program with centralized tracking system that we have dedicated nurses and nurse navigators, nurse practitioners who all they do is lung screening. And I'd say even with that though, right, the VA population is a very unique population of patients. Reaching patients is very challenging sometimes. And so even with as organized as the infrastructure is, adherence sometimes is challenging regardless, because sometimes we just literally lose track of the patients because they move or they don't have their number anymore. We've lost the contact information. So it's not that the tracking system isn't working or the team isn't there. It's just, we just don't have access, right? However, and that's not too uncommon from the county hospital side of things, right? Now, what's interesting is a sharp contrast, with the IU Health system. We have built a centralized system, but that's for our downtown Indianapolis Hospital, right? Now, IU Health is a very huge system with multiple community hospitals. So there's the suburban region of Indianapolis, which is a completely separate health financial, I guess, packet of the part of the hospital. And then there's other areas in the state, right? And each financial pocket basically can run things however they want to, and so some of them have chosen to be centralized, some of them have not, some of them chosen to be hybrid. And I will say, I think we know this, there are studies to show this. There is no question and there is no doubt that centralized systems have better success rates overall, better uptake, better adherence rate, better quality of care with regards to speed to diagnosis and workups, even in scenarios such as with IU Health, where a fully centralized system is not possible because of the financial structure of things. At least centralizing parts of it or a hybrid model would also be better than a completely decentralized system.
Yeah, great. I agree. It's better than nothing, right? So, well, hopefully you'll be able to continue to increase the centralized aspects of it, but it is a challenge, and also all of us know that it's a challenge to get support from leadership. It's I don't know, there must be other priorities for the system leaders, and you have to make a good argument. So I don't know what that argument is. I haven't found the answer in my current position, but all right, let's move on to another topic. Back to you, Dr. Suzuki. One of the interesting but very au courant topics was the use of AI machine learning in screening for lung cancer. And you two invited radiologists and IT folks from MIT, Stanford, and Harvard to summarize the current status and future directions. So let's start off with question one. Dr. Adams and co-authors gave us an update on AI and machine learning, but they also write about ultra low dose techniques to reduce radiation exposure with the screening. Would you please elaborate on this topic of ultra low dose and the topic of image noise?
Yeah, sure. I'm by no means a technical expert. With any radiography, dose of radiation is always going to be a concern, and I'm sure someone is or will come up with a lower dose CT, the so-called ultra low dose CT. I am in fact working with a company that is working on making a smaller scanner. More with the goal of making it more of a mobile scanner, but that also means the power source is smaller, so the dose is going to be lower. So, but lower the dose, the less the image quality usually. So, I think then that makes it more challenging to interpret the result, and I think that's where improving sort of the downstream processing becomes relevant to overcome the technical issues. And certainly machine learning, I think, is where that can help with even if the image quality is lower, the machine learning may be able to overcome that in terms of the image analysis. So I think that kind of goes hand in hand as the technology of the scanner gets better, so that we can lower the dose. The machine learning part also has to get better to kind of be able to process the imaging.
Thinking about machine learning and the platforms that are out there to assess lung cancer risk prediction. Are either of you using such platforms? I'm not going to say any company names. And if you are, is it worth the investment?
I would say we have not acquired any of the machine learning platforms or AI platforms. I would love to. However, this kind of goes back to your prior point, which is getting the administrators to buy in and understand the importance of all of these modalities.
So I think Civil is a very well validated model that we were actually fortunate to have the people that were involved in creating it write the chapter. The better thing about the Civil is that they made it publicly available. It's free. So as long as you have someone that understand coding, I think it's Python coding, that you can use the software. In fact, I found a high school student who is into coding, and she got we were provided the code, and so we are using it currently. because it's free, more for a research purpose at this point to see if we can improve even on that, meaning if we incorporate other, clinical other factors, can we improve on the performance of these, these models? So right now we are using it more for research purpose, but we have had discussions about, since we're going to have this data, should we share this with the patient, or could we use it to actually tailor our management afterwards? So what the program does is it gives you sort of an annual risk of lung cancer in a percentage annually up to 6 years, right? So there may be nothing on the CAT scan. There could be no nodules. It can be RAS2, whatever, but the software spit out a percentage of that patient's lung cancer risk. So again, we're only using it for research purpose currently, but we have had discussions about, sharing that data with the patient or using it clinically. Like if you were going to follow 3 to 6 months, 6 to 12 months, maybe based on the CIBL data, we would err more towards the 6 month versus 12 month. I think that's reasonable, right? Because I don't think we have anything better at the point. But it is publicly available and free, the CIBL.
All right, the code that was written by the teenager?
No, I have the high schooler who understands the coding. You do it for us.
Got it.
But the code is publicly available. But you have to have someone who understands the Python to use it.
Let's move on to another topic. And Dr. Suzuki, I know you do some of these adjuncts to lung cancer screening imaging, but the fourth topic you guys selected was another hot one, and that is liquid biopsy. Liquid biopsy is all over the cancer world. And so you invited Dr. Mara Antonoff and colleagues from MD Anderson to write about liquid biopsy as an adjunct to lung cancer screening. So let's start, though, with you, Kay, and talk about your research focus on adjuncts. Can you briefly summarize what you're working on currently?
Again, we were fortunate enough to have experts write the topic, but adjuncts to screening can come in several forms. Radiomic is one of them. Liquid biopsy is one of them. I have research attacking it, the same issue, sort of from a different angle, and that's by looking at the nasal epithelium. The chapter mentions Percepta, the airway biomarker, so it's sort of along the same line, but this is based on the premise that if lung cancer is caused by exposure to cigarette smoke, there's carcinogenic changes that's happening where the cancer is in the lung. But could we see similar changes in the nasal epithelium that is also exposed to the cigarette, right? So, people have developed airway biomarker for sort of a nodule stratification purpose. But now I'm sort of using the same principle to say, can we risk stratify for someone's lung cancer risk to use it as an adjunct to screening? So it's not to diagnose a cancer, but it's to identify someone at high risk for harboring lung cancer. So someone who may not meet eligibility currently, down the road, we may have a tool to say, hey, you're still at high risk, so you should get screened, right? So that's the whole goal. I think that's the whole idea about adjuncts, is sort of we can personalize care as to personalize the lung cancer risk. So I'm attacking it from sort of the airway biomarker angle. So thanks for bringing attention to that research.
Great. Yeah, we look forward to what you can produce from your continued research. I know you've been working on it for several years, so in collaboration with the folks at BU. Mimi or Dr. Sepra, will you share with the audience which biomarkers have been externally validated to complement screening with regards to what Dr. Antonoff and colleagues put in her chapter?
In table 1 of that chapter, it lists the 4 currently available biomarkers or adjuncts that are currently being used. And I must admit, I personally have not had any experience with any of them. But the first one is Notify Lung, which is a composite test of a panel of antibodies. And the intent of it was really to try to identify the likelihood of malignancy in an indeterminate nodule. And so what this specific test or panel has shown is that patients who have a positive test have a 5.4-fold increase in having of lung cancer incidence. And then also there's the converse, right? A negative or lack of positivity has shown to spare 31% of patients from unnecessary invasive procedures. So that's one of the concerns with, or one of the issues with lung screening is, right? And this, which by the way, obviously AI and machine learning will play a role in it, is by better fine-tuning and risk stratifying which nodules, quote unquote, are concerning versus not, right? We can also minimize the risk of patients undergoing unnecessary invasive procedures. The other test is called Percepta, which Dr. Suzuki just mentioned. It's a genomic classifier, and it's used as a tool to help stratify the bronchoscopic cytologic brushings and ones that would have otherwise been non-diagnostic. So this genomic classifying tool will help up or downgrade the risk or likelihood of the patient having a malignant diagnosis. GRAIL DNA is a blood-based DNA methylation assay. By evaluating methylation patterns, multi-cancer signals can be identified. And so this, once again, is another modality to try to risk stratify for whether or not a nodule is significant. And then Delphi is the fourth one that's currently available. It stands for DNA Evaluation of Fragments for Early Interception. It's an assay that looks at the patterns of circulating free DNA fragmentation. And by doing so, they are able to identify, once again, whether or not, or risk stratify the likelihood of a nodule being a cancer malignancy or not. And the Delphi test has been shown to be more than 96% specific for multiple cancers, including lung cancer.
There is some concerns, I think, with bringing all these liquid biopsies and biomarker testing to real time, that it will just contribute to disparities in screening rates. So those in underserved populations who are already suspicious about just getting a CT scan are going to become even more suspicious about having their blood drawn. And they will not want to even get the CAT scan. Where do you see lung cancer screening in about 10 years? And how do you think we can optimize the screening rates to minimize an increase in the disparities gap?
I do think and hope that in the future, just like the rest of the medicine field has become, everything is about personalized care. I do hope that lung cancer screening will become a little bit more personalized. And I think where we have to be careful is, we can't make it too complicated. We can't make it too pricey. I think when I think of adjuncts to screening, I want to make sure it's a simple test to collect and relatively straightforward. So, I guess blood test is simple, even though it's a blood draw. This is why I like the nasal study, because it's, everyone's used to the COVID nasal swabs now, and you collect it the same way. My hope is that the nasal, if you're identified as a high risk, it actually will convince them to go get the screening CT. So that's my hope, at least, right? And then, so I think it's on us to make the test simple enough, and cheap and available enough for that to happen. Yeah, I will say, as far as these other blood marker tests, I did actually have a patient that came to me after a positive notified test that convinced her to go get the biopsy. It was diagnosed as stage 1 cancer, and then now she has surgery, so she's cured. So I think these tests are being used, and then GRAIL and Delphi, because these are now looking for a lot of cancers, not just lung cancer. Our screening cancer center, we are talking about incorporating this into our practice. I think initially in a research perspective, but to then use that to help us make our decisions. But again, I think there's where we have to be careful. We want to make sure these tests are are simple enough and available enough to everyone, so that it's not just a handful of patients that are getting these tests, right? So that's a difficult question, but I am hoping to make a simple adjunct that will convince even these safety net patients to go get the screening, right? I think that's the key. Is we got to get them. Everyone will in the end will need a CAT scan to see the nodule or the cancer, right? But so the key is, how do we get them to that? And if the adjunct help convinces them to get to that, that's a goal. It's an achievement,
Right. We need like a PSA type test. So, yeah, Dr. Sappa.
Where I would love to see lung screening go would be, like Dr. Suzuki mentioned, personalized care, but also using all the multiple factors, right? So using AI and machine learning, using the adjuncts, and using the scans themselves, and basically stratifying the patients. Like, so X patient with this background and, this test can get the next scan in 2 years instead of in 6 months, or instead of a year, right? Or it's okay to get this next scan in 3 years, it'll be fine. So decreasing the frequency, which hopefully will facilitate compliance, right? If it's one thing to get a patient to commit to getting a CT scan every year, it's another one to say, hey, you'll be fine, we will call you back in 3 years, right? But then, of course, once again, having the infrastructure, whether it's a centralized program, the software, the buy-in from admin, to be able to safely do that and not risk losing the patient 3 years from now, right? But that's where I think lung screening is heading, and I would love to see it head and be successful in that.
Yeah, I think we really are just trying to focus on building the infrastructure right now. You're right. I mean, it's crazy that we have to try to catch up to making it as routine as mammography, colonoscopy, pap smears, et cetera. So prostate exams. All right. Well, I'm really excited that we invited you guys to be the co-guest editors of this issue, because you definitely are experts in this area, and you are very passionate about it. And I look forward to seeing what you bring to our scientific conferences and the literature on these topics. There's so many areas that you can address, and I hope you have a posse of trainees and research coordinators, et cetera, to help you bring these projects and ideas to fruition. I want to thank both of you for participating in the podcast as well. So good luck, and maybe we can have follow up in 5 years, 10 years. Thank you.
Thank you for joining us for our 7th Thoracic Surgery Clinics podcast devoted to lung cancer screening. The 4 articles discussed, as well as 7 others, are in the November 2023 issue, Volume 33, Number 4. The series is available for individual print or online subscriptions. Visit www.thoracic.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter /X @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.